How does that work? What happens when it cools down? It will crystallize. Thank you. So essentially, it's a concentration of a liquid, water, and the sugar. Same thing with the stone. It's a critical concentration of certain minerals that end up forming crystals. The crystals, as they go further, will grow into small specks of sand, and the sand will form together into anhydrous, which will form a stone. Temperature helps you form the syrup. The pH of the urine affects the solubility of the crystals. Calcium and phosphate will require higher pH. Uric acid and cysteine will require a more acidic type of an environment. Risk factors. In our country, in our society, heat. Ramadan. We fast. Ramadan يخلص في الصيف. 2 months later, you have people in droves with kidney stones and renal colic in the emergency room. And the reason is they're not drinking enough liquids in the evening to help dilute those crystals and flush them out, and they end up being formed into stones. So exposure to warm, dry weather, inadequate fluid intake. Men more likely have stones because they're usually more in the labor, more in the fields, more in the stressful environment that's more sweaty, and they lose more liquids and don't drink enough. Usually happens in middle-aged people. Caucasians, strong family histories have a tendency to reform stones. Sedentary lifestyle also doesn't help. Presentation. Majority will present with renal colic. Renal colic, pain. I don't know, has anyone here had renal colic? Lucky group, mashallah. Well, remember, 3 kinds of pain. Labor pains, tooth pains, renal colic. Very bad. I've had renal colic a few times. I was doing surgery. I was in the middle of surgery. Okay. And in the middle of a very crucial point of surgery. And usually as a surgeon, you're super focused, all your senses are gone. So for pain to come in and distract you is a problem. But for pain to make you collapse and stop your surgery, you can imagine how severe it is. It's very bad. On a grade of 1 to 10, it's a 9.5. Okay, so renal colic is a very painful condition. Sometimes it's associated with nausea and vomiting, restlessness, may even get a UTI on top of renal colic, causing fever, chills. Hematuria is a common presentation. If patient has a solitary kidney, decreased urine output, and if the bladder stone, the kidney stone travels to the ureter to the bottom, it may even start irritating the bladder and cause frequency, urgency, and feeling of bladder fullness. Best imaging modality is a non-contrast CT scan. It's the gold standard. Specificity is almost 100%, not quite, but almost 100%. It also detects signs of urinary tract obstruction, such as hydronephrosis. Ultrasound misses about 20% of the stones. KUB will miss about 40% of the stones. The reason is some stones are radiolucent, such as uric acid stone, cysteine stone. And the other reason is a KUB will be affected by the bowel gas and the contents of bowel, which overlie the kidney when you do the imaging, so not very sensitive in picking them up. IVP is a test we talked about earlier, which honestly, the last time I ordered one about 15 years ago. So, is this projecting well from the back? Can you see it? Yes. Classical kidney stone seen on plain film. It's a calcium oxalate stone, what we call radio-opaque. So you need to comment. The stone is overlooking the kidney shadow on the right side, seems to be in the mid to lower part of the kidney. And then you have to comment on the size of the stone. You would need to measure it with, if it's a plain film, you can measure it with a ruler, or if you have the software in front of you, you can measure it with the cursor. And it's very important to know the size of the stones. Why? Because 90% of stones that are 5 millimeters or less will pass spontaneously, and they will require just proper hydration, fluids, etc. If they're larger than that, between 6 to 7 millimeters, the chance is about 70%, and above 7 millimeters, the chance is only 20%. Another classical image of a stone. This one is more elongated. It's probably has gone into the renal pelvis, into the ureter, and it's stuck at the UPJ. That's the typical location of the UPJ on the left side. This is beginning of what's called a staghorn stone or a jackknife stone. Looks like jackknives, okay? This here is what's called a staghorn. You know what a stag is? Okay, wow. So this stone forms a cast into the collecting system of the kidney. And the reason the stone forms is they're usually made of calcium, magnesium phosphate stones. And these stones are soft, they're not very hard, and they're usually infective stones. They're associated with E. coli or Proteus mirabilis or Klebsiella. And that's why they grow into the collecting system and they form a cast. So they become very hard to eradicate, and they require surgery and multiple sessions of surgery. Non-contrast CAT scan. Typical stone appears as a calcified speck over here, for example, in the periphery of the kidney. So when you give contrast, if you want to better delineate the collecting system, you need to make sure the patient is not allergic to contrast, which happens about 1 to 2% of people, and you need to make sure that their kidney function is okay because contrast is nephrotoxic. This is what a normal IVP looks like. So what an IVP is, or a CT urogram is, we give the contrast and we wait for about 15 minutes for the contrast to make its way into the collecting system. And once that in the collecting system, we start taking images. So we'll see the anatomy of the collecting system. So this is the KUB of the right large staghorn stone. And this is what the IVP looks like. So the same stone over here, and you can see the collecting system behind it being hydronephrotic with hydrocalysis. You don't see the ureter on this side, so it's totally blocked. But you see the ureter on this side, which is a normal side. These clips are from previous surgery, so ignore them. Other tests that can help include testing the serum calcium, phosphates, checking the urine's pH, plain X-rays, and CT scans. We talked about stone size. Now, there are 3 narrow areas in the ureter. These are usually where the stones like to get stuck. The UPJ is the first one, where it crosses the iliac vessels is the second one, and the last one is the UVJ, the uretrovesical junction. And that's usually the most common area where the stones get stuck. Acute treatments include giving the patient adequate pain controls, whether non-steroidals, giving them opioids, hydrating them. If they're nauseous or vomiting, you admit them for IV hydration to preserve their kidney function, and even give them antiemetics. First episode of stone, confirm the diagnosis with radiographic evidence of the disease. You do a comprehensive metabolic evaluation only if the patient is a pediatric age group or the recurrent stone former. So try to find out why they're having recurrent stone. I can tell you the majority of people who have stones are not drinking enough liquids. Okay, it's only a minority that have a inborn error of metabolism, such as cystine stones or hyperuricemia. Of course, the best thing you can do if the patient passes the stone, or if you get a fragment of it once you're treating them, is to analyze the stone. So you know what the stone composition is made of, and maybe you can better counsel the patient down the line. For example, if it's a uric acid stone, look them up for hyperuricemia, advise them to cut down the red meats, give them allopurinol, and so on and so forth. So treatment. ESWL, also known as extracorporeal shockwave lithotripsy, is useful for kidney stones that are less than 2 centimeters in size. ureteroscopy and endoscopic lithotripsy using Holmium laser, using EHL, can be used for stones in the bladder, ureter, or kidneys. For a stone that is larger than 2 centimeters or a staghorn stone, like I showed you earlier, we can do percutaneous surgery. So we can puncture the kidney to the abdominal wall, put a scope directly in the kidney, and apply our energies to break the stone within that scope, and then try to evacuate as many fragments as we can. This will require multiple sessions if the kidney has a complicated staghorn like we saw earlier. Rarely, very rarely, do we do open surgery or laparoscopic surgery for kidney stones. The shockwave machine looks something like this. This contains both a C-arm and a shockwave generator that focuses on the stone and breaks it through cavitation. This is what a PCNL looks like. The scope goes directly into the calyx of the kidney. A laser fiber comes out of the edge of the scope and fragments the stone into smaller fragments. Ureteroscopy, we have two kinds of ureteroscopes: a rigid ureteroscope, which will only go down to the distal ureter, and we have flexible fiber optic scopes that will go all the way up. These are very fine instruments. They break easily, and they don't have a large diameter, so they don't allow us to have that much functionality and visibility at the same time, because you need fluid irrigation. The nice thing about urology is we combine these modalities with fluoroscopic imaging, so we're always monitoring ourselves. We know exactly where we are at all times by using continuous fluoroscopy. So this is what the view inside the ureter looks like. You can see that we have the pink walls of the ureter all around. We're inside that cylinder. That blue structure on top is a guide wire, which exactly is what its name implies. It's a guide. It helps us understand where the direction of the ureter is and where to follow it. And as we're going up the ureter, we see these two stones in the middle of the ureter. We would just park about 3 millimeters from the stones, and within the fiber optic, pass a laser fiber, place it on these stones, apply the energy, fragment the stones, and come out. That's a laser fiber. And you can see the red beam coming on its tip on the stone itself and fragmenting the stones into smaller fragments. Majority of stones, like we talked about, are calcium oxalate. Some are calcium phosphate. About 10% are uric acid stones. Struvite or infective stones happen about 15–20% of patients, and very rarely inherited metabolic errors of metabolism cause cystine stones. You don't need to know about these. This is just, if you get in your slides, just don't worry about them, read over them. So stone prevention. Now, this is something that I would like you to know about. It helps you in your career, especially if you're in the family practice realm in the future. This was looked at critically in multiple university settings where they said, okay, let's dissect and find out what's the stone composition, 24-hour urine collection, and let's tailor-make a treatment for these patients to prevent stone formation. The other camp said, no, let's just ask everyone to drink lots of liquids. Same effect again, okay? So unless you had a particular disease like hyperuricemia or hypercystinuria, increasing the fluid intake will work in about 90% of patients. These people have to walk around with a water bottle as big as the one you have out there. Good job. You should not restrict calcium intake. People used to think that, cutting down your dairy products would be good. No, it's not good. Decreased sodium intake is good. Decreasing red meat intake is good. But the most important thing is increasing your urine output to more than 2 liters per day. Now, to achieve a urine output of 2 liters per day, if you're exercising in the gym, or you might need to drink 4 liters a day. And if you're doing nothing and just sitting in the air conditioning all day, you might need just 2 or 2.5 liters. Depends on your perspiration, your body size, your body type, etc. Relapse rate is high, about 50% of the first 5 to 10 years will relapse. So if you've had a stone before, that's your biggest risk factor of forming another stone. Same goes for family history. If someone in your family has a stone, you have a very high chance of forming stones. Even if you're not related, I have husband and wife who get stones. It's probably related to their food, probably related to their, their drinking habits, because they're living together and they have the same thing. Lab data may help in people with recurrent stone formations, looking at their calcium, bicarbonates, creatinine, chloride, and their vitamin D and parathyroid hormone levels. When you look at the 24-hour urine collection, the most important two aspects of a 24-hour urine collection for recurrent stone formers are urinary volume. أول شيء الطلفي. So a patient comes in with a bottle with 1 liter in it. You have your cause. They're not drinking. Period. Number 2 thing is pH, and the others are important. But the first two, the volume and the pH, are the most important 2 things to look at. Prevention, water, increased fluid intake. We talked about this. So to conclude, calcium oxalate stones are the most common type. One of these is on your question MCQs. Okay. Hint. CT scan with non-contrast is the diagnosis of choice. Increased fluid intake for acute treatment and prevention. And only a limited evaluation is necessary after the first episode. Okay? You don't need to do the whole full metabolic record. Any questions? Okay, that leaves us with just one topic, the topic of infertility. I think it's a bit too much to... You'd like to go ahead? Okay. You surprised me.